just say a big thank you to Liz and Deb from Fasd for helping us with getting this set up. And we're very excited about our involvement with Fasd and the opportunities that we have to grow our FASD special interest group. And I'll just say a little plug for the conference that's coming up. So if you haven't registered already for our pre-conference workshop, please get on there and register and check out the program for the Fasd conference as well. There's lots of great FASD talks in the program. So now to introduce our speakers for today, we're very grateful to have Anna and Raimond here to present to us. So Anna is a neuropsychologist with over 20 years experience working in the field of intellectual and neurodevelopmental disability. So Anna works for Tamariki DHB and in private practice. In the Child Development Service in Tamariki, she has a primary focus around assessment and diagnosis of intellectual and neurodevelopmental disabilities. Anna has extensive experience in the field of FASD, including assessment, diagnosis, and support for people with FASD, and teaching and supervising of other professionals. Thank you, Anna. And then our second speaker for today is Raimond. So Raimond is a pediatrician in Tamariki. Hopefully I'm saying that correctly for the Kiwis online. Sorry for my Australian accent. He has a special interest in children with developmental disabilities. Raimond has more than 10 years experience in a multidisciplinary assessment and support of children with FASD. And Raimond is also the current co-chair of the Australian and New Zealand Clinical Network. Thanks, Raimond, and I'll hand over to Raimond and Anna to present the webinar today.
Cool, thanks, Tash. Great to see so many people online. Thanks for attending, it's really great. Yes, so we're going to talk to you today about diagnostic formulation of FASD, talk a bit about differential diagnosis, talk about comorbidity. We have some time at the end. We'll try and make it short and sweet so we have enough time for questions. So please feel free to enter questions and we'll try and answer them as much as we can at the end. Okay, we'll just move on with the karakia first.
Whakataka ki te uru, whakataka ki te tonga, kia mā kina ki uta, kia mā taratara ki tai, I he ake ana te atakura, he tio, he huka, he hauhu, tihe Māori ora. All right, so I'm just going to start by talking about formulation, which won't be new to any of the psychologists in the room. Psychological formulation is one of the core competencies of psychologists. And the process of formulation draws on and integrates a wide range of biological, social, interpersonal, and cultural factors. And it considers the person's whole story. It's not an expert pronouncement like a medical diagnosis. It's more of a plausible account of what's going on for a person. It's a tool used by clinicians to relate theory and research to practice. And systemic formulation or team formulation is possibly less familiar to some of us. It's a really useful process for FASD assessments because they're so complex. And systemic formulation is often used in child, adolescent, and disability settings. It's a process that provides an opportunity for a real collaborative discussion so that the team around a child or young person can form a shared perspective of what's going on for them. So the biopsychosocial model, this is a really popular model that's been adapted for use across different psychological settings. It really helps with the process of formulation by helping people recognize and pay attention to the many factors that contribute to a person's presentation, and also to conceptualize the interconnectedness of the various elements. So the biopsychosocial model was first conceptualized by George Engel in 1977, And it really offered a nice alternative to the prevailing biomedical model that had dominated until the mid-20th century. And he suggested that to understand and respond adequately to patients suffering and to give them a sense of being understood, that clinicians needed to attend simultaneously to the biological, the social and the psychological aspects of their illness. So the process of formulation, it's not rocket science. It's about summarising a person's core difficulties and their strengths. It draws on and integrates a wide range of interpersonal, biological, social and cultural factors, as you saw in that biopsychosocial model. And it draws on psychological theories and principles and the formulation itself progresses. It explains how difficulties have developed and how they've been maintained within the current context. And within the process of formulation, you can come to an agreement around diagnosis, which is useful. But importantly, the process of formulation considers the person holistically. So it's not just looking at is this Fasd or not, it's about all of the contributing factors. And it provides a foundation from which actions and interventions can arrive, and those interventions are more likely to be useful if we've taken a holistic look at the child or young person. So now I'm just going to work through a complex case where a systemic formulation process within that biopsychosocial framework was used to understand this child's difficulties and to improve outcomes for him. This case is anonymised, but I did contact his mum, and she was more than happy for me to use him for this presentation, so that's cool. This is an 8.5-year-old male. Well, he was 8.5 at the time that this assessment, the initial assessment, began. He was referred to pediatric psychology with a highly suspected intellectual disability, and so the initial request was for intellectual disability assessment. And right through his file, there was reports of probable or suspected prenatal alcohol exposure, but nobody had ever confirmed that. So I think looking at this, if we've got that biopsychosocial model in mind, looking at this from the social perspective, his mother is New Zealand Māori and his father is Samoan Chinese. He's one of 7 children. He did have 2 siblings living in Taranaki, but when I first saw him, his brother, who he was quite close to, had been whāngaid out to a family member in Auckland, which is about 5 hours from us. And he had one sibling, his little sister, that lives somewhere different, but does actually attend the same little school that he attends. All of his siblings have been removed by oranga tamariki, or social services here, because of ongoing, long-standing alcohol and drug issues within the family home and quite severe domestic violence, including physical abuse towards the children. And the little boy this little boy had quite serious scars on his body as a result of that. So this lad had been in oranga tamariki care from the age of 3. He spent 18 months in a group home, and then he moved in with foster caregivers at the age of 4.5. And they're a lovely family who have taken him on as home for life caregivers. So he's still there to this day, which is fabulous. At the time of this initial assessment, he was presenting with some real, quite severe challenging behaviours and trauma, behaviours related to trauma and attachment. And he was asking lots and lots of questions about his biological family and why he couldn't live with them. And he was asking about the cigarette burns on his body, and he was making up stories about how his caregivers had hurt him and things like that, which was getting quite concerning for the caregivers. And he was really pushing back against people that really cared for him in his life, both at home and at school. And all of that, he was asking a lot about his culture and where he came from. And all of this really started, we figured out at this point, when his brother had gone to live in Auckland, and he'd gone here to an uncle that they didn't know existed. And so that was important for us to understand. And then looking at this from a family history perspective, he had a strong maternal family history of severe hearing impairment, long-standing addiction issues in both parents and the wider family. His brother, we diagnosed with Fasd a couple of years prior to this assessment, and he had other siblings who had known learning difficulties. His mum also had a history of learning difficulties and poor schooling, but there's no family history of diagnosed intellectual disability or other neurodevelopmental disability that we knew of. So looking at this case from a medical perspective, I'm not going to go into too many details because Raimond's going to tell me I'm wrong, but no, he knows more about this stuff than I do. But basically this child had quite a complex medical background. He had something called vascular association, which meant that he had multiple physical challenges. He had cleft lip and a deviated spine and lots of heart problems, lots of things going on for him medically. He had a severe hearing impairment. And when I assessed him, he had bilateral hearing aids with a transmitter. Unfortunately, despite that hearing impairment being picked up when he was a newborn at the newborn screening, he was lost to services. And that was about the vulnerability at that time, social vulnerability and transience. When he was somewhere between the ages of 3 and 4, he had grommets in, but the real severity of his hearing impairment was not picked up until he went into that home for life caregiver situation. So it's unclear how much early language exposure was affected by that hearing impairment. He had Griffith's done when he was Italy, and they found that he had some delayed milestones, particularly his language and communication, and he had slightly delayed cognition and motor skills. Like I said, prenatal alcohol exposure was strongly suspected but not confirmed, and there was notes from various people that had seen him throughout his childhood suggesting the possibility of ADHD, but that had never been explored or diagnosed. From an education perspective, he had long-standing academic difficulties across the curriculum. There'd been lots of remedial supports put in place, but those difficulties continued. And he was more than 2 years behind with reading and writing, slightly better in maths. An Oars application had recently been made. So that's for those Australian colleagues out there, that's for long-term disability funding for school. So that would give you specialist teacher and teacher aid supports in school. And that had been declined. He wasn't at a severe enough level for that. And he was receiving the ICS is in-class support, and that's really just some teacher aid support, but that had also been stopped. He did have ongoing input from the specialist teacher for the deaf. And she was very helpful in the formulation process around trying to understand what was going on for this lad. He was really socially immature. He was social and he loved to be social, but he really struggled with developing and maintaining friendships. He was frequently dishonest and taking things that didn't belong to him. His caregiver needed to check his bag every night when he came home from school and send things back. And with those behavioural concerns that were happening in the school setting, there was real concern at the point of the ID assessment around placement breakdown. And the school was starting to really struggle as well. So I did the cognitive assessment with him. And as you can see, the suspicion of intellectual disability didn't pan out. The top bar there, the darker one, is his full scale IQ, which is in the low average range. And people were quite surprised about that because he wasn't able to function really in that low average range. What you can also see though is a lot of scatter across the indexes on his cognitive assessment, with verbal comprehension being in the extremely low range. And adaptively, so his adaptive function assessment was, he showed severe impairments across multiple domains within the adaptive functioning, and his social functioning was really poor. So he would have met ID criteria adaptively, but certainly not cognitively. And he had significant language difficulties. And at the point of that assessment, we really suspected that he had a developmental language disorder, but that was quite complicated by that lack of early language exposure and not a lot of understanding around those early years for him. So it's really helpful at that point to have a good discussion with the specialist teacher for the deaf, who was able to contribute to the formulation around, okay, what are we going to do next? What are our hypotheses here? And so at this point, we thought, because the behaviours that were really on top were those attachment, trauma, loss of cultural identity, loss of whānau, all of that stuff was really bubbling for this child at that time. And so we thought it would be very important to address that as soon as possible. Before we started considering further assessment, we needed him to be stabilised a bit more. So lots of things happened. His caregivers, the father of the Home for Life caregivers was Māori, and he himself reconnected with the local marae and connected this boy with the local marae and helped him learn some more about his culture. They also connected with the uncle in Auckland who'd whānaui'd the older brother, and they made sure that the brothers were able to communicate more, and they had visits and what have you. And this boy started really figuring out where he'd come from. And there was a little bit of, they put in place some trauma counselling for him through a male play therapist who was really useful. And that person, the counselling was more useful because they had access to that cognitive assessment and they understood what his profile looked like, so they could target that therapy appropriately. And actually what we saw just with those interventions was real improvement in this child's behaviour and the distress that he was expressing. In the ID assessment report, we recommended, and in conjunction with the teachers and the caregiver, who actually happened to be a teacher as well, and the teacher for the deaf, we thought, let's get an SLT involved and get an assessment done there. And we thought that it was important for us to get confirmation of prenatal alcohol exposure and carry on with further neuropsychology testing for FASD assessment and referral back to paediatrics for them to do their medical developmental part of that assessment. And so then, after things had settled down for this lad, we did go ahead and carry on with the FASD part of the assessment, and we got confirmation of significant prenatal alcohol exposure. And we did some more neuropsychology testing in the context of possible FASD. So that diagram that you can see there, that illustrates the huge number of domains that can be affected in children who've been prenatally exposed to alcohol, and the real complexity of these assessments. And for this child, the testing certainly found several domains of impairment, including executive functioning and attention, academic deficits that we talked about, and adaptive and social functioning. And the speech language therapy assessment that happened resulted in a diagnosis of developmental language disorder. We also found an area of real strength for this boy, which was in his visual memory. And the number of domains of impairment, and knowing this child's social and medical background really does illustrate how complex diagnostic formulation can be and the importance of doing that well. So Raimond's just going to talk now about a medical and developmental assessment for him.
Yes, so as Anna said, well, this is a cool illustration of a case that is really very, very complex as it gets. So you would wonder, what is the role of the pediatrician? Well, first thing, of course, is help the psychologist make sense of it all. So that's what we do. No kidding. But a case like this is, okay, what is my role? And I think this one illustrates nicely. We can input a whole lot of stuff. We look at the medical background and see what the importance of this is. This child has a significant congenital condition, multiple organs involved. He has had inconsistent follow-up. He's got a hearing loss. So there's that whole background. However, with this condition, children usually do not have developmental delays. But then his delays, there can be issues with that because sometimes, well, actually often, we may neglect them medically because developmentally because we're focusing on the medical issues. The hearing issue as an example, there's all sorts of angles to that. And the medical stressors can also influence the behavior of the child and the child's emotional development. So actually, we input all of that stuff into the diagnostic formulation. Okay, if we move away from this case, let's just talk about differential diagnosis and comorbidity of FASD. So they're not the same thing. Differential diagnosis may be a number of things that have got nothing to do with FASD and are a different diagnosis. Sometimes a child can have two separate conditions, like in this child. What we see frequently is the comorbidity. The child has FASD and multiple other things, right? When we look at the differential diagnosis, we need to be aware FASD is actually, medically speaking, a diagnosis of exclusion. So you need to exclude a number of things first. Main differential for us as clinicians is the congenital stuff. They can be genetic or non-genetic, and can be other neurodevelopmental conditions. Throughout this talk, I'll mention a few publications. Just be aware, I just picked a few publications out that illustrate what I'm saying. I'm sure there's other literature. Perhaps some of you have done or produced studies that illustrate the stuff I'm saying. If you have, then just please bring it up at the end. We can talk about it. Just be aware of it. I just picked out a few studies. A nice one was Popova. She did a systematic review in 2016 and looked at comorbid conditions in FASD. There was a systematic review, and they actually find a whole pile, 428 comorbid conditions, including just about everything in the ICD-10. But there was clearly a pattern, and most prevalent were things having to do with congenital malformations or deformations, chromosomal stuff, and then of course like a big package of mental health and behavioral things. What they found the most actually in that systematic review was abnormal results on peripheral nervous system, so sensory things and similar stuff, conduct disorder, and then language disorder. So those were the things that stuck out, as well as otitis media. I'm not sure whether otitis media actually comes in, but anyway. Let's just talk about the congenital conditions that can look like FASD. First of all, there's a group of genetic syndromes. They all have specific names. We'll show you a few of those things. Then nowadays, because we do microarray genetic tests, sometimes we find little bits and pieces of chromosome that are abnormal or deleted or duplicated. We don't always know what it means. It can be something subtle. So those micro deletions and micro duplications, I think genetically speaking, are more difficult for me to distinguish from FASD. Okay. Then talking about non-genetic stuff, there are a few other exposures that can give injury to the brain. One of the most well-known is the fetal anticonvulsant syndrome. Sodium valproate, Epilim in New Zealand, gives a syndrome, actually looks quite strikingly similar to FASD, with changes in the midface and changes in the brain, in the way the brain works. This stuff you should actually have out of the history, so it shouldn't be a problem in day-to-day practice. Okay, now I was talking about those genetic syndromes that have some features of FASD. A nice publication that I would recommend about that is that Canadian publication that I have up there, where Ab Chudley participated in that one, 2014. So they have a long list of conditions that can look a bit like FASD. However, if you look up those conditions, many of those children look either way more dysmorphic than just what FASD looks like, or they've got complex medical issues and other stuff going together with neurodevelopmental things. So I think that list of conditions that I have up there is not that difficult to distinguish in day-to-day life from FASD, but you need to look at that. Okay, let me just go to this one. All right, so my clinical bottom line thinking about genetics in FASD is, first of all, you need to carefully examine the children for this morphology, meaning not only the facial features of FASD, but also the other details. As an example, not that long ago, I had a child measure the child's head. It's too big. The child's got macrocephaly. That's not FASD. That's a genetic syndrome associated with macrocephaly. Just an example. So you need to examine them carefully. Some cases request a microarray. We would do it in all those cases with intellectual disability or dysmorphology. Just be aware that a normal result doesn't mean there's not a genetic cause, right? We will refer to the geneticist quite frequently. That would be all the kids with intellectual disability plus dysmorphology, all cases with significant medical pathology. So if a child has a developmental problem and you know, renal failure or whatever, it smells a bit like something else, and you need to exclude other genetic conditions that can cause that, right? Cases with abnormality on the microarray that I'm not sure how to interpret it or how much does it play a role or not, I would refer them. Conversely, if you've assessed a child and does not have dysmorphology and not intellectual disability, then your genetic review probably won't be of benefit. Just as an aside, and I think you all see that, is these kids with the family history of intellectual disability and the child's got alcohol exposure. Can be all sorts of things, can be multifactorial genetic, can be intergenerational FASD, but they are kids we see frequently. Okay, next bit in our comorbidity mainly is things that go together with FASD or sometimes separately, but we need to distinguish them and put them into the diagnostic formulation. There can be specific learning disorders, can be language disorders, ADHD, autism, conduct disorder, and oppositional defiant disorder. If you look at FASD and behavior, Popova did a nice study in 2019 where they looked at the WHO prevalence study in Canada, and they looked at those that had FASD versus those that did not have FASD. And actually, neurodevelopmentally and behaviorally, the kids with FASD were indistinguishable from children with other developmental disorders, which means that there's nothing that particularly sticks out in those kids as a typical pattern. Then another example is this Australian meta-analysis from Sydney of 2016, where they looked at behavior rating scales. I think it was a child behavior checklist, and compared kids with FASD to those without FASD. And the kids with FASD had much poorer ratings on the behavioral outcomes than those without, but the differences in the behavior weren't significant. So they had a similar pattern of internalizing and externalizing issues. The things that did stick out for them were items of rule breaking, attention, and aggressive behaviors on the behavior checklist. The attention problem is an interesting one because we see in our minds, well, I do anyway, kids with ADHD as the chaotic, busy ones, but actually when you look at the research, many of them don't necessarily have that. They've got the attention deficit. Okay, so my bottom line of FASD and child behavior is, for me as a pediatrician, the behavior disorder is often the reason for the initial referral. FASD presents with a range of behavioral comorbidities, can be conduct disorder, ODD, ADHD, other disturbances. I add to that in younger children, I am reluctant to make a diagnosis of conduct disorder or oppositional defiant disorder, but their behavioral profile looks like that. So there is no specific behavioral profile in kids with FASD. For me, what makes them stick out is the pervasiveness and the severity of the behavior disturbance and the non-response to management of it. The profile is not difficult, but that pervasiveness and severity and non-responsive to treatment is, I think, the thing that sticks out. Right, next bit, FASD and ADHD. The majority of children that we diagnose with FASD have comorbid ADHD. Numbers are a bit variable, but a lot of people come around 70 to 75% of children with FASD that also have the ADHD. There's an interesting article I came across from Young in 2016. So this is an American expert consensus guideline for cases where you have a co-occurrence of ADHD and FASD. And they underline with numbers that I'm not going to bore you with, but that a diagnosis of FASD is associated with increased risk for ADHD, but you also have the inverse of that, obviously. There are red flags in patients with ADHD that may make you think of FASD. Obviously, that would be the history of antenatal alcohol exposure, or children that have physical features of FASD. But it's also the kids that present with predominantly inattentive ADHD with a bit of impulsive behavior. It doesn't all make sense. And then a group that I've seen quite frequently is children that have been diagnosed with ADHD and do not respond well to treatment. They have had methylphenidate behavior intervention, and actually it has not helped much. And then, oh, you've increased the dosage of the methylphenidate, you get nowhere. Those cases, I think you've got to start thinking of another diagnosis instead of just pure ADHD. Okay, clinical bottom line, ADHD is the most common comorbidity in FASD. FASD often initially is diagnosed as ADHD. There are red flags in children with ADHD that should make you suspicious of underlying FASD. If you find ADHD in children with FASD, by all means, treat the ADHD with medication. I do that. However, I don't think that the response to stimulant medication is as predictable as in a child with pure ADHD. Right, language disorders in FASD. There's just a few examples of research. Most recent one is Hendricks in Cape Town, South Africa. Looked at communication in children with exposure to FASD, and they looked at longitudinal studies, meaning studies on FASD where there were at least 2 measure points, right? So kids that had been alcohol exposed had lower scores on receptive and expressive language before 3 years of age, but after 3 years, it actually corrected quite a lot. Another study was Coggins in 2017, looked, I think there was in University of Washington, if I'm right, they looked at a large cohort of children with FASD, primary school age, and they found meaningful deficits in language and social communication. And I think very few of us would argue about that. Rasmussen in 2011 tried to see if there was a specific pattern of what kind of language disorders these children have, and they looked at specific tests, the TOLD P3 and the CREVT2. I haven't done those tests, I'm not sure how they worked, but they did see some differences in these specific tests in the kids that are exposed to alcohol. Just putting it all together, FASD and language impairment, there is evidence about it, but it's a bit mixed on how much difficulties and what pattern of difficulties it causes. But overall, they do have a language delay. Some studies suggest that the difficulties as measured with a WISC or similar stuff would be worse on verbal IQ than on performance IQ. I think our case had the same thing. The gap was quite big there, the one you presented. But there is no core deficit or consistent pattern of language difficulties in these children. However, looking at it overall, there seems to be a difference between younger children and older children. The younger ones display more global language deficits, so that's just generic stuff in receptive and expressive language, whereas the older children have more deficit in syntaxes of language, meaning understanding and interpretation of sentence and sentence structure, so more subtle language deficits. I think we do see that, and when our kids with FASD are assessed by SLT, that's what they see. Right, so the bottom line about FASD and language disorder for me, that's my bottom line. I made it up, so you may have comments about that. So language disorder is common in FASD. It's expressive as well as receptive language. Syntaxes, you need to look at that in especially the older children. Some of these kids have a broader language disorder, which we call developmental language disorder. As a side comment, these language problems, we often underestimate them clinically because these kids come across as quite engaging and you actually don't realize, this child's got a language problem. Putting all that together, if you do a nice FASD assessment, if you're able to get a speech language therapy assessment as part of your neurocognitive stuff, go for it because we think it is important. Right, autism and FASD, there's a lot about stuff and I've had a lot of discussions with people about that. The clinical impression is that many children with FASD have traits of autism. They're a bit rigid in their thinking, the difficulties with social communication. But having said that, for me as a pediatrician, I feel they feel different than children with pure autism, if there's any such thing. They, on the surface, are more sociable. So though you tick off a few autism criteria, they actually look more socially engaging on the surface. Stevens did a publication on this in 2013, looked at a group of children with FASD and compared them with kids that didn't have FASD. They do score lower on social skills, higher on behavior problems, and higher on autism subscales. Right. As a comment that I've seen, but I think other people say the same thing, that a number of kids that we see at certain age with FASD have previously been diagnosed with autism. And when you look at them, they don't really meet those criteria. They've got FASD. I've seen the converse happen also. We make a diagnosis of FASD and subsequently somebody else gives a child a diagnosis of autism. With all due respect, I think that's wrong. Anyway, clinical bottom line is many children with FASD have autism traits. What we do clinically is that if a child with alcohol exposure meets all criteria for ASD, it's a slam dunk ASD diagnosis, we make that autism diagnosis, and that's the primary diagnosis. However, I do acknowledge that some children perhaps should have both diagnoses. I've got a few kids with a diagnosis of autism on my patient load that, yeah, they are autism, but I don't know, their severity and their response to management of autism is really quite complex. And I wonder, this child may be one of those that has both. I do think that we need to be finicky about diagnosis, and we do need clearly distinguish, has a child got autism, FASD, or both, and we need to look in a finicky way at your criteria. Right, I think this is my last group of issues, is FASD and trauma, adverse childhood experiences. Often I get the comment, how can you say a child has FASD because the child has been through such a lot of trauma. So trauma in early childhood is extremely common in children that we assess for FASD. It can be all sorts of things, neglect, but paternal mental health issues, abuse, what have you. And this has significant consequences on a child and a child's life. You would think that the effects are cumulative with the effects of FASD. So yeah, how can you distinguish that? There's a bit of research on that. I'll just pick out one thing. This is out of a PhD study, I think, from Price. Looked at children with both alcohol exposure with trauma and compared those with children with just alcohol exposure. And actually, they were functionally similar. Parents or children with alcohol exposure tended to have more difficulties than children with just trauma. And their conclusion was, where children have both exposures, probably the alcohol exposure is the more likely driving force behind the difficulties of that child. I think what many psychologists would say also is in trauma certainly does reflect on a child's behavior, but they respond more to treatment than what a child with FASD would do. Clinical bottom line, many children with FASD have trauma. If the trauma is severe and recent, we wouldn't immediately assess for FASD, but we would put in place a number of things to manage the trauma, give the child a stable environment, and then assess the child. Trauma does not exclude FASD. If you have both, you just need to put the adverse childhood experience into your diagnostic formulation and perhaps not get a hernia about which aspect is the more important or not. The child got FASD, but there's also a history of trauma. Right, so a few key points for me about the medical developmental assessment. I think in what I showed you there, for me, it's way more complex than having a look at the child and do the measurements in the face and is this FASD or not. We do a hell of a lot more than that. We need to exclude medical and genetic conditions, but more time consuming is we have to do an in-depth developmental assessment, look for comorbid developmental and neurobehavioral issues. We look at the developmental trajectory. And actually, in many of these cases, we do that already because within the public health system in New Zealand, many of these kids would be under the care of the pediatrician before they go to the psychologist. This may be a bit different in psychologists that get referrals through youth justice, but for me, many of these kids, we see them before Anna does. Anyway, that whole blurb, I was talking to you about that whole differential diagnosis and the comorbidity, we input that into the diagnostic formulation.
So just coming back to the purpose and the benefits of that multidisciplinary or team diagnostic formulation when we're assessing for FASD, it helps us to identify the best way forward and it informs our interventions. It really does encourage collaborative work. It clarifies hypotheses and questions, provides an overall picture, so taking that holistic look from multiple perspectives, and it incorporates cultural understanding and emphasises the strengths as well as the challenges. Some additional benefits from using formulation and teamwork. It really draws on and values the expertise of all of the team members, including and that includes professionals and caregivers and other important adults in these children's lives. And it increases team understanding and empathy and reflectiveness. It gathers all of the key information in one place. And it helps you deal with the core issues and not just crisis situations and crisis management that we often find ourselves doing with these kids. And it achieves a consistent team approach to understanding that child and therefore the interventions. So just wrapping up, a way to deal, team formulation is a really good way of dealing with the complexity that these cases often present for us. The process might be quite new to some medical professionals who would be more used to the differential diagnosis or medical model, but diagnostics formulation is certainly supported by the psychologist and the team during FASD assessment. Multidisciplinary or systemic formulation might also be quite new to some psychologists, those that don't have so much experience maybe in child adolescent or in disability work, but it's not rocket science. FASD assessment reports and the formulation needs to be written in a really accessible way. Professional reports can sometimes be really lengthy and technical, and it makes them inaccessible and therefore quite unhelpful to many people. So that's a bugbear of ours, to make sure that our reports are useful and not just for a select few people. So we need to remember the underlying purpose of Engel's biopsychosocial model, that it's not only to understand and respond adequately to the patient's suffering in a holistic perspective, but it also gives them a sense of being understood. That's our last slide. Yeah,
thank you. We got a little bit of time for questions. Before we do the questions, just another thing. I don't know if we can't answer all the questions. We're also happy to have some debate via the clinical network. So feel free to send us comments via the clinical network.
Thanks, Anna and Raimond. So we've got a few questions on the chat. And if you're still pondering your questions, feel free to pop them in there or in the Q&A box. There's a few sort of questions about availability. We'll talk to those later. One person has asked here for a New Zealander, so I'll ask you guys this one. Wondering what the current gold standard guidelines are for FASD diagnosis within New Zealand, and particularly they're wanting to know from a psychologist's perspective.
So we have the Canadian guidelines and the Australian guidelines, and are we in agreement around which one of those we're using? I personally quite like the Canadian guidelines because they're more specific for a psychologist in terms of the details within the cutoffs and things, but the Australian guidelines are very, very accessible, which I do like about them, and that in essence they're the same. So many professionals in New Zealand draw on either which one of those. Have we got a consensus yet in New Zealand?
Yeah, the bottom line is at the moment, I think the majority of clinicians and psychologists would use the Canadian guidelines. I wouldn't frown on it, but if somebody does the Australian guidelines, that's also fine. And I know you're reviewing them at the moment, so there may be an update soon, but I think if the honest response would be, they're both actually fine, not that different, but the majority of clinicians will follow the Canadian ones currently.
And there's a couple of comments on that in the chat for you guys. Sarah has commented and said, it's definitely the Canadian guidelines, but there has been some discussion about this. And absolutely right, Raimond, we're currently going through a process of revising the guidelines, and New Zealand is also going through that process as well. So another question for you guys: how does the extreme prematurity and severe neonatal congenital, not sure if this person wants to put their hand up and ask this better than I am, impact on the diagnosis?
Oh, that's very cool. I like that question, because I should actually have put that into my presentation. Extreme prematurity certainly is combined with a lot of developmental delays, a lot of behavior issues. In a way, you can also see it as a form of brain injury. The problem is, of course, that with heavy alcohol use, you actually may trigger prematurity. So there may be a link with the prematurity and the alcohol. So I'm not so sure you can distinguish them. But if a child, okay, let's put it this way. I've seen many kids with extreme prematurity and learning delays, but actually the severity of their behavior and aggression is often not as severe as in kids with FASD. So in my mind, if I would have a child with extreme premature and being off the walls and quite aggressive and if you think, this sounds quite pervasive, I would go ahead with the FASD assessment. But it's again, as with other developmental things, you can't totally distinguish it. And that's again a case, I think that child should warrant full neuropsychology anyway, because it has had a form of brain injury in those terms. So whether you would be looking for FASD or not, if a child with extreme prematurity has significant developmental and behavior issues, I would recommend a neuropsychology assessment irrespective of FASD. But in some cases, I would still make a diagnosis of FASD, but it may be a bit biased because I would pick out the ones with quite severe behavior disturbance, quite severe conduct disorder. I don't know what other people think of that, but the ex-prematures have a pattern of attention deficits also, of course, and it sticks out quite strongly, learning deficits and attention deficit.
Yeah, and executive function problems.
And executive function problems. So there is an overlap. So if you, let's put it in another words, if you would assess them for FASD, they would often meet the criteria.
Okay, we've got lots of questions coming in here, so we better get on. So the next two questions are kind of linked. So James and Stella, I feel like your questions are quite linked. So James says, great presentation, thank you. Where I work in Australia, our government child protection and health systems are currently strongly driven by the broad assumption that FASD perpetuates negative stigma with respect to Australian Indigenous populations.
Yep.
Any experiences or issues in New Zealand regarding how cultural issues impact on the challenges of diagnosis?
Yep, we can say a lot about that. That's a really important point. You of course need to try and move away from stigmatization of the family and the child. So I think we try to be very careful with that. Ideally, and some parents have asked that, these children in New Zealand context, you would have a Maori health worker or Maori psychologist supporting you through it, so you have a better understanding, and that especially that the family feels more comfortable with what you're doing. So I think you need to be well aware of that in day-to-day practice, and we try to address that. I don't know if we address that well enough. Anna, have you got
I mean, part of the diagnostic formulation process and that systemic formulation is to include those cultural supports and cultural experts and people that can contribute to that to help us with that aspect of our formulation. Stigma, it's a hard one, and I often struggle with parents who biological parents who find it really hard talking about the period of the pregnancy where there was prenatal alcohol exposure, and it takes a long time to get through that, and that's okay. And it's about them being ready for that. And I think it's just going to be a shift over time.
If I can just add one thing to that, if you talk about child protection services, perhaps also youth justice, I think culturally sometimes there's not enough informed consent before referral. So I've seen quite a few Maori families referred, and yes, they know kind of what it is about, but I don't think they've been informed well enough and properly enough. And to me, I think that's the biggest deficit. I'm not saying we do it perfectly culturally, far from that. But the biggest criticism, if I would look at what I've been doing, I've had more than one family, it hasn't been well enough explained to them what this is about. And that's unfair, it's not correct.
That's a really good point. That issue has been raised a lot here too about informed consent, particularly from families of different cultural backgrounds.
Yeah,
that's a really important thing to consider. The next question that we have here is about why are pediatricians more likely to focus on giving an autism or ADHD diagnosis rather than FASD? A bit more to that question, but I'll give you that part.
Oh, that's a very cool one. Yes, so that is true, because people, the ADHD, there's a simple answer to that, because ADHD, we get many referrals for that, and many children with FASD, they do look like kids with ADHD. So the simple thing is to do what you always do, and bang, there you got a diagnosis of ADHD and off you go. Right? I think in your questionnaire, and we have that in our questionnaire, pre-developmental assessment, we send out the questionnaire to the families, we ask about alcohol use, and I would ask about alcohol use as a standard in any developmental assessment. But ADHD is an easier diagnosis, number one. Number two is not all clinicians are aware of FASD. Many people may not want to touch it because they think it is too complex. It's actually not, just get over it and do it. But actually the feeling out there is this is quite complex. Some clinicians, but I think they are becoming more rare, don't really believe in FASD. They think, oh, what are we making this fuss about? And we're just stigmatizing people. That was quite common 10 to 20 years ago. That's less common now. In New Zealand context, I've had more than one case of a child with FASD diagnosed with autism. And one of the cases I know for a fact that the clinician did that because he thought in that way the child would get services. Because in New Zealand context, autism is recognized as a developmental disability, whereas FASD is not, right? FASD with intellectual disability is, because then the intellectual disability counts as a disability, but FASD cannot go under, without intellectual disability, does not go under disability label. So you get less services than with autism. So people sometimes think, well, they look a bit autistic, just give them that diagnosis and the family will get a bit of funding and they get this and they get that. I can understand that reasoning. I think from clinical practice, I'm not in favor of that, because then these children get incorrect services, incorrect management by other clinicians, and you see sometimes that those incorrect management principles are actually harmful. So I think it confuses things way too much if you give a child with FASD a diagnosis of autism. I've also sat in a few FASD diagnostic formulations with psychologists where somebody in the group emphasizes the autism of the child quite strongly. Well, actually, nah, it is a bit rigid, but actually it's not autistic. It got FASD. That's what we need to address. Autism and ADHD in New Zealand are well known by any clinician. A way easier diagnosis to make. We have processes for that. FASD is more complex as a diagnostic process. I assume in Australia it is a bit similar. I don't know.
Pretty similar. And your answer has gone to one of the other questions on the chat too from Stella you know, touching on how for some medical professionals, they may not have awareness about FASD, and it may not have been something they were trained in diagnosis for, and may not be comfortable in doing that diagnosis.
Yep.
So we are unfortunately out of time. We do have other questions in the chat, and I'm really sorry that we didn't get to cover all of those. But thank you all for being here for the presentation today. And thank you to Anna and Raimond for taking the time to do this presentation. There's a couple of comments in the chat about will the presentation be made available? We are currently recording it, so we'll chat with Deb and Liz about getting that out to people, and we can chat with Anna and Raimond about availability of their slides after the presentation. So thank you all, and see you next time.
Okay, cool. Thank you. Bye-bye.